Hello everyone, welcome to RAAONLINE. I'm Dr. Abinaya. I'm a consultant pediatrician. So in Nelson-based pediatric teaching, in the chapter discussion on neurology, the next topic is a very important topic. Okay, right from MBBS point of view and from the initial first year MD or DNB postgraduates, this is a must-know topic, right? Not just for the theory, for the practical. So we get a lot of cases on meningitis. So this will be very useful for all of you. So let's get started on acute bacterial meningitis. So we know meningitis is one of the most serious pediatric infections because it is associated with a high rate of complications and morbidity and mortality. So prompt antibiotic therapy will alter the natural course of the disease. So that is why an immediate referral, or you have to immediately intervene and start the antibiotics for these children. Previously, say more than around 30-40 years ago, the most common organisms for bacterial meningitis were all Haemophilus influenza, Streptococcus pneumoniae and Neisseria. But with the advent of effective immunization coverage on Haemophilus and pneumococcal, this has come down. So we see a little bit of difference in epidemiology nowadays. So now Haemophilus influenza has come down a lot. What we see now as the most common organism is this, which is Streptococcus pneumoniae. So this is the most common cause of bacterial meningitis. So this is essentially a disease of young children, and most often the 90% of the cases occur between 1 month to 5 years of age. So we have certain risk factors for meningitis. Let's see what are these risk factors. Children who are raised in poor socio-economic conditions, poor hygiene, poverty, who has not got the vaccinations, overcrowding, all these are risk factors. Recent colonization with pathogenic bacteria, say some sinusitis, otitis media. So some infections or contiguous infections can be a nidus for meningitis. And sharing of closed spaces, say a meningococcal disease in a child, especially in dormitories, in hostels, so that can quickly spread. So close contact with a person who has this invasive disease. And specifically some immunodeficiency, the complement deficiency like complement C5C8, properdine deficiency, they are all prone for meningococcemia. This also we have learnt, isn't it? And T-cell defects are more prone for listeria infections, splenic dysfunction. So these are all host risk factors. And risk factors like a structural abnormality, like a meningocele or a myelomeningocele, CSF leak. So all these are all risk factors for meningitis. So coming to the gross pathologic findings, and then we will go on to the pathogenesis. So when we examine gross pathology, so what we can find is there is a purulent exudate which is covering the meninges, and this is seen especially on the convexity of the brains, sulci, fissures and around the cerebral veins. Ventriculitis, whenever there is meningitis in neonates, there is a possibility of ventriculitis also. All these infiltrates are around the perivascular and vascular involvement is present. So that is why meningitis is an important risk factor for neurological or focal deficits when stroke-like episodes. So whenever there is a vascular involvement, it will lead to vasculitis, it will lead to thrombosis, it can even lead to necrotizing arteritis. So meningitis doesn't just stop with involvement of the meninges. Because of the infiltrates around the perivascular area and because of the vascular involvement per se. So there is vasculitis, there is thrombosis of the veins, there is necrotizing arteritis. All these can cause the complications. And why there is meningeal signs? We always think of meningeal signs, isn't it? So in adults, very easy to elicit the meningeal signs, Kernig sign, Nuchal Rigidity, Brudzinski sign, etc. Isn't it? So why there is meningeal signs? What is the pathogenesis behind the meningeal signs? Whenever there is meningitis, there is inflammation of the meninges, there is inflammation of the spinal nerves and spinal roots. This produces the meningeal signs. So this is very important that you should know. Okay. And so all these I have told, some of these are related to complications. One more important complication of meningitis is neuropathies. So inflammation of the cranial nerves can also lead to cranial neuropathies. So meningitis will always have raised ICP, and the raised ICP, the result is not just one cause, but we have 3 causes here. So we will see what are the 3 causes which will result in raised ICP. Okay. So it can be due to a cytotoxic cerebral edema. So it leads to cell death. It can be because of an interstitial edema. Interstitial edema is because of CSF obstruction. Whenever there are infiltrates, basal infiltrates, all these are going to obstruct the CSF absorption. So that will cause increased hydrostatic pressure, and that will result in raised ICP. Third, there can be a vasogenic edema because of the increased capillary vascular permeability, right? So these are all causes of raised ICP. So what are these? We will see once again. It can be a direct cytotoxic effect where there is cell death. It can be because of an increased hydrostatic pressure because the CSF is not getting absorbed properly, or it can be because of an increased vascular permeability. So these are all causes of raised ICP. So this is again the pathogenesis of whatever we have seen so far. So let me just skip it. So one of the complications of meningitis is hydrocephalus. So the hydrocephalus is due to, we just saw, one is because of the impaired absorption and the arachnoid villi. There can be an adhesions or the adhesive thickening of the arachnoid villi that will prevent the absorption of CSF. So that is one possibility which is happening most commonly. Also all that foramina of the Lashka, foramina of Mejendi, the cerebral aqueduct also can undergo gliosis and fibrosis. So raised ICP, finally hydrocephalus due to these causes. So in meningitis, you know, CSF will have elevated proteins and reduced glucose, isn't it? So I will tell you why there is elevated CSF protein and why there is reduced CSF glucose. So first we will see about the protein. So the protein elevation is due to, because it is an inflammation which is going on, right? So there is an increased capillary permeability or an increased blood-brain barrier permeability. This blood-brain barrier is breached. So there is loss of albumin-rich fluid into the subarachnoid space. So the CSF will become very rich in protein. So that causes elevated CSF protein. And this transduction, sometimes it can continue and can just stay there, causing subdural effusions also. There is CSF glucose is reduced in meningitis. That is because the transporters are ineffective. In meningitis, in the cerebral tissue, what happens? The glucose transporters become ineffective. So because of the altered glucose transports, there is hypoglycorrhea, elevated CSF protein. These are the 2 important reasons behind it. Okay. So now let's move on to the etiology of bacterial meningitis. So the neonatal meningitis, I am not going to talk here, it is covered in the neonatology chapter. So we will just discuss the organisms alone. So in the neonate, in the early onset neonatal period, it is mostly gram-negative, Escherichia coli, Klebsiella, Streptococcus, Listeria, etc. Late onset neonatal meningitis, apart from this E. coli, Staph aureus and Salmonella are also possible. So between the first 1 to 3 months, predominantly it is gram-negative organisms. Beyond this 3 months, you see, now what I told in the first slide, what is the most common organism? Streptococcus pneumoniae. So this becomes the most common organism beyond this 3 months mark. Up to this, we have all mentioned about the gram-negative organisms only. Okay, you got that? Okay, so followed by Streptococcus pneumoniae, Haemophilus influenza, Neisseria meningitidis, and rarely Pseudomonas and Salmonella. Beyond 5 years also, Streptococcus pneumoniae still becomes the most common organism, and Neisseria meningitidis. Here Haemophilus influenza will not come beyond 5 years of age. Sometimes there can be some predisposing factors which will lead to the particular organism causing meningitis. Say in case if there is a shunt which is placed, a VP shunt is placed, or there is a meningomyelocele. So whenever there is open, when there is skin breach is present, we expect staphylococcal organism to be the cause of meningitis. It can be either Staph aureus or it can be Staph epidermidis also, right? So next, whenever there is CSF leak, we think of pneumococcal organisms. Splenic dysfunction, sickle cell anemia, think of Neisseria, especially whenever there is defect in complement system, think of Neisseria. T cell defect, think of Listeria, right? So coming to the clinical manifestations, so meningitis can present predominantly in two different patterns. One is the most common pattern where the fever is prolonged. Okay, there is several days of fever. There is initially, it can start as an URI or it can start as an AGE like of presentation, and then there are non-specific CNS symptoms. The other less common presentation is the dramatic presentation, where similarly what you see in meningococcal infections. So sudden progressive CNS dysfunction, there is shock, there is purpura and sudden death. So this is a hyperacute presentation, and fortunately this is less common. Okay, so these are the two predominant patterns in meningitis. So what are the acute, in the acute presentation, initially the child has fever, right? So followed by headache, vomiting, there can be myalgia, arthralgia, some rash can be present, anorexia, poor feeding. So these are all general non-specific findings or non-specific symptoms that are associated with meningitis. For meningeal signs or meningeal irritation, we refer to these three signs you are all familiar with, isn't it? Nuchal rigidity, Kernig signs and Brudzinski sign. But what the downside of these signs is, it is not well established in a child below 18 months of age. So they are not consistently present. But in older children, definitely you can elicit these signs. So how will you elicit a Kernig sign? So the child is placed in the supine position. The knee is flexed to 90 degree, the hip is flexed to 90 degree. You extend the knee. When you extend the knee extension will be painful for the patient or it will be limited. Okay, so this is Kernig sign. Brudzinski sign, the child or the patient is made to lie in the supine position. When you passively flex the neck, what happens? The patient will have a hip flexion and a knee flexion. So this is elicited by the patient. Okay. So when you passively flex the neck, there is hip flexion and knee flexion. So first, initially the patient is lying in supine with the hip and knee extended. Okay. So this is Kernig sign and this is Brudzinski sign. You should definitely elicit in any child more than 18 months. It might be positive. So we saw some of the complications of meningitis, isn't it? Raised ICP, there can be hydrocephalus, there can be shock. So what are the symptoms of raised ICP? In very young children, bulging fontanelle or separation of sutures can be there. Otherwise, in older children, they can complain of headache, vomiting, abducens paralysis can be there or oculomotor paralysis can be there. Cushing's reflex, that is hypertension with bradycardia is possible. Apnea or hyperventilation, finally stupor or coma. So papilledema can also be elicited, but in an uncomplicated meningitis, papilledema is quite rare. So this meningeal signs, especially neck rigidity or the nuchal rigidity, is absent. We know less than 18 months it is absent. One, severe malnourished children, it is absent. It is absent in a terminally ill child. Very, very importantly, absent in partially treated meningitis, absent in immunocompromised children. So most oftenly, if you work in a tertiary care center, by the time the child arrives to you, a primary care pediatrician would have already given the initial treatment, right? So we are in a position where we will not be able to elicit the neck rigidity. So remember, where all nuchal rigidity is falsely absent, right? This is meningitis, but we are not able to elicit it. Falsely present, okay. So this is not meningitis, okay, this is like a false positive, okay. This is not meningitis, but I am able to elicit neck rigidity, where whenever there is some neck muscle or whenever there is a lung parenchymal, especially in the apical region, parenchymal pathology, you will be able to elicit it, right. This is called meningismus. In an upper lobe pneumonia, you will be able to elicit. In a cervical spine disease, neck pathology, I told you, retropharyngeal abscess, cervical lymphadenitis, some myalgia. Typhoid fever, yes, we have all learnt about it, right? So this neck rigidity you have to know properly where it will be absent, where it is falsely positive. So this meningitis triad, Fever, headache, neck rigidity is very, very rare in children. Even in adults, it is positive only in 40% of the patients. So, what are the complications of meningitis? Now, you have a child with meningitis. You should anticipate the complications. What all it can come? You know, raised ICP is possible. Whenever there is raised ICP, seizures, hydrocephalus, cranial neuropathies, stroke because of vasculitis, the necrotizing arthritis, thrombosis, etc. Right? SAIDH is one more metabolic complication that is seen in meningitis. So, all these are very, very important, both from an exam point of view and clinically this is very, very important. Anemia, yes, rarely. Okay. So, how are you going to diagnose? We need lumbar puncture, right? This is the most important step which will help in the establishing the diagnosis of meningitis. But before doing a lumbar puncture, we should rule out all the contraindications. So, you should know what are the absolute contraindications, what are the relative contraindications, right? Absolute contraindications we will see. If there are signs of raised ICP, how will you know the child has raised ICP? You do a fundus examination, rule out papilledema. Is there any posturing that you can see? Any focal deficits, any focal seizures, please don't do. Do a neuroimaging and then you can follow it up with lumbar puncture. Local infection in the track, needle track, of course that is also a contraindication. Whenever there is in neuroimaging, if there is an evidence of obstructive hydrocephalus, cerebral edema, herniation, these are all absolute contraindications. Relative contraindications are, that is cardiovascular instability. So, hemodynamically if the child is unstable, so there is hypotension, there is overwhelming sepsis. So, correct all this first. Or when there is a coagulation disorder, so there is a thrombocytopenia, platelet count is less than 50,000, there is DIC, so correct it, appropriate correction and then you can do. If the GCS is less than 8, so first you do the neuroimaging because the child is unstable. So, these are all contraindications for lumbar puncture. So, you do these 3 C's we have heard, right? Blood culture is very, very important because 80 to 90% if the child has not received even 1 dose of antibiotics, blood culture is positive in meningitis. Then cell count, C-reactive protein. Procalcitonin, some units do procalcitonin, some units do not do for meningitis. Again, it is a unit protocol. So, apart from these, cerebrospinal fluid, your CSF will tell a lot of information. So, starting from the pressure. So, what is the opening pressure? Of course, CSF pressure will be high in bacterial meningitis. How is the appearance? In bacterial meningitis, it will be turbid. In viral encephalitis, it is straw colored. So, what is the cell count? Biochemistry, so the glucose, protein, and microbiology will tell you the gram stain, acid fast bacilli. You do the CSF culture and others for other investigations like CSF PCR, ELISA can be sent. So, this whole tabular column is very, very important. Clinically, you have to refer this and let's see. Okay, let's quickly go through this tabular column. So, first in acute bacterial meningitis, what will happen? Pressure will be high. You should know what is the normal pressure. Normal pressure is less than 28 centimeters of water. So, pressure will be high. WBCs. So, the cell count will be very, very high, that is at least more than 100 and predominantly all these will be neutrophils. Protein. Protein will also be high. Protein is also more than 100 milligram per deciliter. Glucose. Glucose is decreased. To say glucose is decreased, you need to know the RBS at that time. So, whenever you do a lumbar puncture, just do at that moment only, do a random blood sugar of the patient also, note it down at the CSF slip. Okay. So, if it is less than 50% of the serum glucose, then it is called as hypoglycemia. This is very, very important. So, correlate with your serum glucose. So, this is a tricky situation. Most of us actually receive patients who are partially treated. They have received 1 or 2 doses of antibiotics. So, in such instances, the CSF pressure may not be high and even the cell count is less. Okay, cell counts could have come down, but whatever cells are present, neutrophils will be there. Okay, so neutrophils will be present. Protein can be normal. Sometimes glucose is also normal in a partially treated meningitis. Okay, in viral meningoencephalitis, the CSF pressure can be normal or can be elevated. And leukocytes, predominantly there will be lymphocytes, not neutrophils. Protein will be somewhere between 50 to 200 and generally viral meningoencephalitis, the glucose is normal. except for some viral infections like mumps. This is again very important. Tubercular TB meningitis, right? TB meningitis, the pressure is high, the CSF is cloudy. Predominantly, it is lymphocytes. Okay, in early period, it can be neutrophils, but predominantly it is lymphocytes. Protein is very, very high. See, look at here, 3 grams. So, usually in TB meningitis, we get 1 gram, 1.5 gram protein in CSF. And glucose is also low. Okay, so this is slide is going to be your go-to slide during exams. Okay, for reference. So, other investigations, of course, when you have selected situations, say for an immunocompromised host. So, you ask for India ink stain for fungi. For Mycobacterium tuberculosis, you can ask for carbonyl fusion stain. And when you are doing a viral, if you suspect a viral meningoencephalitis, ask for a viral panel, CSF, HSV, DNA, PCR, enteroviral presence, PCR, etc. Okay. So far we have seen the lumbar puncture, the CSF analysis. Okay. So, next let us move on to the differential diagnosis of meningitis. Most often meningitis is going to be a clear-cut diagnosis. But if there is an altered sensorium, you have to keep in mind of diagnosis like acute viral meningoencephalitis also. When the fever is not very clearly established, but there is altered sensorium seizure, then think of autoimmune encephalitis, think of a demyelinating disorder, a vasculitis disorder, etc. So, these are all going to be your differentials diagnosis. Okay. So, how do you approach a case of bacterial meningitis? So far whatever we have seen, I am going to give you a quick recap before going on to the treatment part. So, when you suspect a child of bacterial meningitis based on the history and physical examination, you stabilize the child first. Okay. Ensure the airway, breathing, circulation is normal. Secure IV access, take the blood samples for culture, very, very important because it is most of the times it is positive. Then assess if the lumbar puncture is safe for the patient or not. You have to rule out all the contraindications. If you have ruled out, well, very good. Do the lumbar puncture, do the necessary tests in the LP. Immediately start the child on antibiotics. That is very important. And continue the antibiotics until you get the appropriate test reports. If the CSF study is not safe, what you are going to do is start the empirical therapy, consider a brain imaging, do a neuroimaging, and then later on you can do the LP. So, what will be your initial antibiotic therapy? So, initial antibiotic therapy will be vancomycin plus a third generation cephalosporin. So, vancomycin dose is 60 mg per kg per day totally. Third generation cephalosporin like ceftriaxone, the dose will be 100 mg per kg per day. Okay. So, this is the total dose per day. Why is this rationale? So, why is this combination? So, the rationale behind this combination will be this third generation cephalosporin is mostly sensitive to Streptococcus pneumoniae, Neisseria, Hib, etc. But 25% of isolates nowadays are resistant to even this third generation cephalosporin. So, that is why vancomycin is added. So, this is your initial antibiotic therapy. So, other choices are, if the patient is allergic to penicillin or cephalosporin, then chloramphenicol or fluoroquinolones. If it is a neonate, add listeria. For listeria coverage, add ampicillin. If it is an immunocompromised host, then meropenem should be your drug of choice. The duration of antibiotic therapy, throughout the course it is given only IV, but the duration is entirely dependent on what actually the organism is. So, if after your investigation, you are not able to identify what bacteria, then give it for 2 weeks, 10 to 14 days. If it is a Neisseria meningitis, give it for 5 to 7 days, a short course. Haemophilus 7 to 10 days, pneumococcal 10 to 14 days, gram negative bacteria almost 3 to 4 weeks. Okay, so gram negative infections, we have to give it for a prolonged period of time. So, should we repeat an LP? Mostly no. If it is gram negative meningitis, we have to repeat. Okay. So, otherwise repeat LP before discontinuation of the antibiotics is not recommended. So, in neonates it is recommended, this is one exception. Gram negative meningitis, you have to do a repeat LP. And if you get a beta-lactam resistant organism, then we can repeat the LP. Okay. So, now we have talked about antibiotics. Okay. What is the role of steroids, we will see. So, again it is debatable, but in Haemophilus influenza, to reduce the hearing loss, it is given. But we do not know it will be Haemophilus influenza before getting on the gram stain and the culture, isn't it? So most of the time we give steroids within the first 4 hours or within the first antibiotic dose we give the steroids. So already if the child has received an antibiotic, then it is not necessary. So neuroimaging of course is going to help you a lot. So when I am going to do priorly means once you have a doubt that the child might have raised ICP, you do a neuroimaging, you rule out herniation, raised ICP, cerebral edema, etc. So in such instances you do before LP. So if there is a low GCS, if the child is having status epilepticus, focal deficits, you do before LP. If the child doesn't respond to treatment also, you can do a neuroimaging in case it was not done priorly. So what neuroimaging will be preferred? It is always MRI. So the neuroimaging findings will be the meningeal enhancement that you can see here. So contrast enhanced MRI, we can see the meningeal enhancement, and these are all various this is a schematic presentation of the meningeal enhancement. So the leptomeningeal enhancement, the pachymeningeal enhancement. So this is a localized gyral enhancement alone is present here. So it can be present anything like this. So this is tubercular meningitis CT finding. So what you can see is the starfish appearance, the basilar exudates, right? The basal exudates, which are all enhanced on contrast. So the natural course of meningitis is when you give the right therapy, fever usually resolves within the first 5 days or within the first 1 week. That is the natural course. Fever more than 10 days occurs only in 10% of patients. It is very less. So when you have a prolonged fever in meningitis, do consider a nosocomial infection, okay, and or any other intercurrent infections or secondary bacterial infections, or what we commonly see is thrombophlebitis if the child is in ICU or ventilation. So think of VAP, etc. So prognosis, usually it is good when we have started the appropriate therapy, but poor prognostic factors we should know. Neonates and infants younger than 6 months, high bacterial burden in the CSF, when we see it is a poor prognostic factor. Seizures which occur later on in the course, not in the first 4 days, but later on in the course, it is a bad prognostic factor. Focal signs on presentation, so focal seizures, focal deficits, they are going to be a bad prognostic indicator, or coma or ICU admission. So this is going to be your poor prognostic factors. Some children can have a post-meningitic sequelae, which is not very common, around 10 to 20% of the patients only. So most common of these post-meningitic neurological sequelae will be, so hearing loss, visual impairment, speech delay, recurrent seizures and behavioral problems. So the sensory neural hearing loss is a most common sequelae. So what is mentioned in Nelson is that in Haemophilus influenza patient, it is present even at admission. Okay, so all patients who are recovering from meningitis should undergo a careful audiologic assessment. So is there any role for surgical treatment? Generally no, only if the meningitis has complicated and has caused an empyema. So I told you there can be subdural effusions, but then if the subdural effusions complicate into empyema, then surgical drainage is necessary. So surgical drainage followed by 3 to 6 weeks of antibiotics. In case there is a ventriculitis, especially in small children, they also need a neurosurgical consultation. So they may require a placement of Abinaya, or if they have ventriculomegaly. So these are all the common organisms and the antibiotics that we have seen. So these are all some special situations have also been mentioned. Okay. So if it is a neonate, usually it is ampicillin plus cefotaxime or ampicillin plus gentamicin. So more than that, usually we give vancomycin plus a third generation cephalosporin, right? When there is a head trauma, skull fracture, etc., usually stick to vancomycin plus cefepime or vancomycin plus ceftazidime. Okay. CSF shunt post neurosurgery. So in these instances, we need to go for cefepime or ceftazidime. So how can you prevent meningitis? Of course, for prevention, vaccination is one thing, and for Neisseria meningitis, for all close contacts, we have to give rifampicin. So rifampicin is given in Neisseria meningitis contacts. So it is given 10 mg per kg per dose every 12 hourly for 2 days. Alternatively, you can just give a single dose of injection ceftriaxone also. And vaccinations, of course, meningococcal vaccine is also available. For Hib meningitis, if not fully immunized, completely give a rifampicin dose for Hib meningitis contacts also. So, it is given 10 mg per kg BD or 20 mg per kg OD for 4 days. So, with this we come to the end of this chapter on bacterial meningitis. So many points, important points we have discussed, the organisms, how to diagnose, what are the CSF parameters that you need to know, the empirical antibiotic therapy, the duration of therapy, complications, etc. So, I hope this presentation is useful for all of you. Thank you.